Hi, everyone. I am Jane Kyla Barossa, a second-year nursing student. Welcome to this video lecture on endocrine disorders in pregnancy, an essential topic especially for future nurses like us. Today, we're diving into two of the most common and high-impact endocrine conditions affecting pregnancy: thyroid dysfunction, like women with hypothyroidism and hyperthyroidism, and diabetes mellitus, including type 1, type 2, and gestational diabetes. We'll talk about their definitions, pathophysiology, how they affect the mother and fetus, how we screen for them, and of course, how we manage them. Grab your notes. Team bread, because this one is packed with critical nursing knowledge you'll definitely need. First off, what do we mean by endocrine disorders? These are conditions where glands produce either too much or too little hormone. Pregnancy causes hormonal changes that affect thyroid function to support her fetus. One major player is human chorionic gonadotropin, or HCG, which stimulates the thyroid, leading to an increase in the demand for thyroid hormones, such as the hormones T3 or triiodothyronine and T4 or thyroxine. This happens because the fetus relies on mom's thyroid. This is crucial for regulating metabolism, thermoregulation, and fetal neurodevelopment, especially during the first trimester before the fetus produces its hormones. When it goes off track, either underactive, hypothyroidism, or overactive, hyperthyroidism, it can lead to complications for both mother and fetus. In hypothyroidism, the thyroid fails to produce enough thyroid hormones, T3 and T4. It is a rare condition in young adults and especially rare in pregnancy because women with symptoms of untreated hypothyroidism are often anovulatory and unable to conceive or become pregnant. Signs and symptoms include fatigue, weight gain, cold intolerance, vomiting, extreme nausea, and myxedema, which is described as swelling and drying of the skin. They often mimic normal pregnancy symptoms, making diagnosis tricky. The thyroid fails to produce enough thyroid hormones, T3 and T4. As a compensatory mechanism, the pituitary gland responds by releasing more TSH, or thyroid-stimulating hormone, which can lead to slow metabolism and impacts energy use and development. A woman who does conceive can then face another obstacle in that she can have difficulty increasing thyroid functioning to a necessary pregnancy level, which can result in increased risk of miscarriage, anemia, preeclampsia, because the fetus doesn't get enough support. It can also lead to low birth weight and even impaired fetal neurodevelopment. Screening is done via serum TSH and free T4 levels. Universal screening isn't currently recommended, only if the patient is high risk. For example, personal or family history of thyroid disease, autoimmune disorders, infertility, or goiter. A high TSH and low free T3 and T4 confirm hypothyroidism. Treatment? Simple. Levothyroxine, a standard treatment for hypothyroidism, is used to supplement their lack of this hormone. A woman who is taking levothyroxine needs to consult with her primary care provider when she is planning on becoming pregnant, to be certain her dose of this will be high enough to sustain a pregnancy. She needs to come for an early diagnosis and close follow-up as soon as she suspects she is pregnant or 1 week past her missed menstrual period. And heads up! Pregnant women often need dose increases of about 30–50% to simulate the increase that would normally occur during pregnancy. After the pregnancy, the dose of levothyroxine prescribed for pregnancy must be gradually tapered back to the pre-pregnancy level for both her health and so she can breastfeed safely. Now, before we proceed, let us test your knowledge by asking you this question. Why do you think levothyroxine doses need to go up during pregnancy? Now for hyperthyroidism, when the thyroid produces too much hormone or overproduction. The most common cause? Graves' disease, an autoimmune condition where the body produces thyroid-stimulating immunoglobulins. These mimic TSH, overstimulating the thyroid gland. It is more apt to be seen in pregnancy than is hypothyroidism. Signs and symptoms include weight loss, palpitations, heat intolerance, rapid heart rate, irritability, anxiety, and exophthalmos. And yes, these can also be mistaken for just being pregnant. Undiagnosed hyperthyroidism during TSH pregnancy can lead to heart disease because the excess thyroid hormones, T3 and T4, significantly overstimulate the cardiovascular system. These hormones increase the body's metabolic rate, which in turn raises the heart rate and cardiac output. Over time, the continuous demand for the heart to pump faster and harder can strain the heart muscle, potentially leading to arrhythmias. In pregnancy, the cardiovascular system is already under extra pressure, and her heart is already stressed due to increased blood volume and metabolic demands. She may develop heart failure because her heart cannot manage the increasing blood volume that occurs with pregnancy. Moving on to its pathophysiology and effects in pregnancy, since there's an increased levels of T3, triiodothyronine, and T4, thyroxine, the pituitary gland senses high level of thyroid hormones and tries to shut down further stimulation of the thyroid by reducing TSH production, thus suppressing the TSH level. This mechanism leads to speed up metabolism. In pregnancy, this fast metabolism results in maternal and fetal complications, such as gestational hypertension, fetal growth restriction, low birth weight, and preterm delivery. Diagnosis of hyperthyroidism or positive TSI is confirmed with suppressed TSH and elevated free T4 or T3 levels. Treatment for hyperthyroidism during pregnancy involves the use of thioamides such as methimazole, tapazole, and propylthiouracil PTU, which work by reducing thyroid activity. Current clinical guidelines recommend PTU during the first trimester due to its lower risk of teratogenic effects compared to methimazole. However, after the first trimester, methimazole becomes the preferred drug because PTU carries a risk of maternal liver toxicity with prolonged use. These medications, however, cross the placenta and may lead to congenital hypothyroidism in the fetus, potentially resulting in an enlarged thyroid gland or goiter. This can become critical if the fetal goiter grows large enough to obstruct the airway, complicating resuscitation at birth. Therefore, the lowest effective dose should be prescribed, and women must be advised to carefully monitor their dosage to avoid omissions or duplications. If maternal hyperthyroidism remains unregulated, the fetus may be overstimulated in utero, leading to neonatal hyperthyroidism. Affected infants may present as jittery, tachypneic, and tachycardic at birth. Regarding breastfeeding, women taking small or minimal doses of thioamides are generally permitted to breastfeed, but large doses may contraindicate breastfeeding due to the drug's excretion in breast milk. Before we dive into our last topic, here's another reflection time. Test your nursing knowledge by reflecting and answering this scenario. You're caring for a pregnant patient on PTU. What labs do you need to watch, and why? Now, let's dive into our last topic, the diabetes mellitus during pregnancy. Diabetes mellitus is an endocrine disorder in which the pancreas cannot produce adequate insulin to regulate body glucose levels. The disorder affects 3% to 5% of all pregnancies and is the most frequently seen medical condition in pregnancy. Diabetes is divided into various categories that can be used to predict a pregnancy outcome. Here are 3 types of diabetes we see in pregnancy: type 1, type 2, and gestational diabetes mellitus, or GDM. Type 1 is often autoimmune, meaning our own body attacks the pancreas, results in minimal to no insulin production. It is caused by beta cell destruction, thus pancreas fails to produce adequate insulin for body requirements. Type 2 develops more slowly, often during adulthood. It is caused by insulin resistance and beta cell decline as well as lifestyle. While some insulin is still made, the body becomes resistant to its effects. And then there's gestational diabetes, which usually appears in the second half of pregnancy due to hormonal changes. This is usually resolves after completion of pregnancy. Even in women without diabetes, pregnancy naturally causes some insulin resistance. Why? Hormones like human placental lactogen, estrogen, progesterone, cortisol, and catecholamines increase. As these hormones increase, insulin resistance happens to support the fetus. These hormones work to make glucose more available for the growing fetus. In healthy pregnancies, this insulin resistance protects the fetus from hypoglycemia. But in diabetic mothers, since there is an insulin resistance, it means insulin doses often have to increase, sometimes even double, to prevent hyperglycemia, because this resistance can push blood glucose levels dangerously high, especially starting around week 24, which can be dangerous for both mom and baby. For the mother, uncontrolled diabetes can lead to hypoglycemia, ketoacidosis, and hypertension, especially if there's pre-existing kidney damage. Managing blood glucose becomes a daily balancing act between preventing too high and too low sugar levels. Let's talk about the baby. Because of the mother's high glucose, the fetus produces more insulin, which acts like a growth hormone. The result? A macrosomic baby, often over 10 pounds. That sounds cute, but it can lead to shoulder dystocia, C-section delivery, or even birth trauma. Uncontrolled diabetes can also cause congenital anomalies, especially if blood sugar wasn't regulated during the first trimester, which is crucial for organ development. At birth, neonates are prone to hypoglycemia, respiratory distress, and hyperbilirubinemia. Here's a quick visual recap. Pregnancy leads to hormone increases, which causes insulin resistance. That leads to higher maternal glucose. The fetus counters this with high insulin, which promotes overgrowth and risk for post-delivery neonatal hypoglycemia. All pregnant women are screened for gestational diabetes. A fasting plasma glucose of more than or equal 126 mg/dl or a random glucose of more than or equal 200 mg/dl can confirm diabetes if repeated. The standard diagnostic test is the 75-gram oral glucose tolerance test, OGTT. After fasting, the woman drinks a glucose solution. Blood samples are collected at 1, 2, and 3 hours. If 2 or more values are abnormal, GDM is diagnosed. Insulin needs vary throughout pregnancy. Early on, less is needed due to fetal glucose uptake, but as insulin resistance peaks around 24 to 28 weeks, insulin needs increase. A 2:1 mix of intermediate to regular insulin is common in the morning, and 1:1 before dinner. Oral hypoglycemics aren't used as they cross the placenta and may harm the fetus. Daily glucose monitoring is a must. Hypoglycemia is treated with milk and crackers, not juice alone, to prevent rebound hyperglycemia. If glucose is elevated, ketone testing is needed. 2 positive ketone tests mean the body is acidic. This requires medical attention. Lastly, some women may opt for an insulin pump, a small device that delivers insulin continuously. It mimics the pancreas by offering both basal insulin and mealtime boluses. The insertion site should be changed every 1 to 2 days to ensure good absorption and prevent infection. Pump therapy requires frequent glucose checks, including a 2 a.m. test early on. Since it is a device, there are precautions when it comes to swimming, bathing, and site care. And that's it. But before I end this, here's another reflection question for you for the last time. How can nurses help pregnant women with diabetes maintain optimal blood glucose control? That's for you to think and reflect. Reminder: as nurses, we can improve outcomes by offering consistent education, advocating for timely screenings, and ensuring close monitoring to prevent complications that may affect our patients. To wrap up, managing thyroid dysfunction and diabetes in pregnancy is crucial for both maternal and fetal health. Early detection, appropriate therapy, and regular monitoring can significantly reduce risks. Thank you for watching this lecture. Stay informed and keep advocating for optimal care in pregnancy. Don't forget to share this with your fellow nursing students, and see you in the next session. Goodbye!